Hello everyone. This is Dr. Kim. It's always a pleasure to be able to reach out to you via interesting case that I have the pleasure of seeing here at UTSD. Today's case is going to be a recurrent odontogenic keratocyst, a recurrent OKC. And we all know from literature that odontogenic keratocyst has a high prevalence for recurrence. That's why they need to be followed up with radiographs with a regular interval to ensure that the early recurrence can be detected and treated accordingly. So this is a case, unfortunate, I guess, case for the patient who is female in her 60s. So when you look at this patient's reconstructed panoramic radiograph, again, this scan was taken outside of our clinic. We see that, or at least I hope you see that, there is an altered kind of trabecular bone density in the area of missing tooth number 17. And at the first glance, this opacity extends from alveolar crest all the way to the left mandibular canal, and somewhere from the area of 17 to tooth number 18. And I think most of you are seeing a radiolucency here, but you will see that from sectional view or multiplanar reconstruction view. We should also check for the area, the mesial aspect of the lesion as well. Okay, now let's go ahead and I think in my previous video, I talked about odontogenic keratocyst in someone in his or her 20s, but this is in 50s. And if you recall from that video, there was no evidence of root resorption or displacement. And again, that's the similar feature that we see here. I don't see any overt evidence for root resorption or displacement. So now let's go ahead and dive into the area of interest. I want you to see how the area looks in the axial plane. And look at the bone density of the affected side to the unaffected side. And you may be wondering, oh, well, Dr. Kim, how come this odontogenic keratocyst isn't radiolucent? Why does it look actually more radio affect than the right affected side? And it's not because that this area has healed with irregular bone density, but rather I would presume that this area, I would suggest that this area has been grafted after its initial surgical exploration and surgical intervention. Unfortunately, what I do not know is when the surgery was done. You know, that would be an important, I think, piece of information that I am personally interested. But at some point, you know, this area was nicely cleaned and then had a grafted material placed. But now, let's see, here is this radiolucency kind of developing around the roots of number 18. A well-corticated radiolucency. So it extends from the distal aspect of number 18 and it kind of wraps around buccal of the distal root and also the buccal aspect of the mesial root as well. And that's what we see in this sagittal view. And again, no evidence of root resorption, right? Let's look at it right here. There's a lesion. It's kind of just spreading within the marrow space. Look at the thickness of the adjacent buccal plate. It's nice and uniform. At least as of now, there's no evidence of thinning of the buccal plate or the displacement. And as we saw in the axial, no root resorption has occurred. So this is following the characteristic radiographic feature of OKC, where it tends to spread along the marrow space. Now, the other radiolucency that we saw at the superior aspect, even though it looked more prominent and better visualized on panoramic image compared to this one, where we really couldn't discern the presence of radiolucency, right? You probably didn't know it until I mentioned it on panel, but this lesion, or I shouldn't say lesion yet, this area, even though its bone density is low, I'm not entirely sure as of yet whether this is a recurrent lesion or not. It may just be that the graft material did not fill this defect entirely. So again, knowing the date of surgery would be helpful. I really don't see a well-corrugated margin either. So I'm not sure. I'm not convinced that this is a lesion. It could be, but I'm not as convinced. But this one for sure, there is a lesion. Okay. You know, my question is, I know this area has been biopsied already and it's determined as recurrent odontogenic keratocyst, but I wonder if this tooth had to be sacrificed. Oh, this is the one thing that I wanted to talk about in the previous OKC case involving the left maxillary sinus. The surgical treatment of OKC typically involves, aggressive curettage or even doing peripheral ostectomy and treating with carnoid oil or some other chemicals to kind of, kill off those remaining OKC cells. And so in maxillary sinus, right, you wouldn't be able to do any kind of like peripheral ostectomy because you're only surrounded by very thin walls of maxillary sinus. So I was wondering how an oral surgeon would go about treating the maxillary sinus lesion. He or she establish a drainage and allow or give a chance for the lesion to decrease in size. And if it does, maybe you can do an excisional or complete removal of the lesion. So that was a question that I wanted to talk about. It's really challenging. Whereas when you have an intrabony lesion like this, yeah, you may have to possibly sacrifice tooth number 18, but when you remove this tooth and remove that lesion entirely, you can curate it or remove this lesion entirely and get a very good margin of the bone, and again redo a graft and allow the body to heal, and you have again like a good chance of getting rid of the linings, cystic linings of OKC entirely, whereas it's very difficult to do that in the maxillary sinus. So yeah, that's all I wanted to talk about. And we don't see any evidence of mandibular canal constriction in this case either. And I'll be curious to know whether there has been displacement of the canal. Well, that's the one on the right side and the left side. Not much of change, right? Okay, well, thank you again. That's all I wanted to kind of share with you folks. I just as I was looking at it, I was seeing kind of bifurcated mandibular canal right here. And was trying to follow where that nerve goes to. It's arising somewhere here and it courses anteriorly like that. Oh, look at that. Oh, look at that. I think it inserts right into the distal root of number 19. Maybe the other branch goes to, oh, hard to tell. The other branch may be going to number 20. That's really, really cool. Normally, I didn't get to always see the course of the neurovascular bundle, but since we have very sclerotic graft material, it's allowing us to better visualize it. That's really, really cool, by the way. I didn't even notice that when I when I looked at the scan previously, but as I was recording it, I noticed this neurovascular channel. that's arising from the main branch, inserting itself into this root. Okay, visual of 18 and also 19. That's very, very cool. Very, very cool. Anyway, thank you. You can see how I can get easily carried away by this, interesting findings in CBCT. Thank you very much, and I'll see you next time. Take care.